Welcome everyone to another episode of Arthritis at Home. Today we have the pleasure of speaking with Anne Macleod. Anne, how are you today?
I'm good, thanks. Pleasure to be here.
Anne is the president of the Arthritis Health Professions Association, the AHPA, and we're going to talk quite a bit about her role in that organization today, but you're also a trained physiotherapist, an extended role practitioner working in a shared care collaborative practice with the sole local rheumatologist in Northwestern Ontario, and is also an assistant professor at the Northern Ontario School of Medicine. I think as we get started, Anne, before we start talking about the AHPA, I think some of our listeners might not be familiar with the term or role of the extended role practitioner. And maybe you can just tell us a little bit about what that means.
Sure. So I am a physiotherapist, and then I'm trained as an advanced clinician practitioner in arthritis care, which is a training program in Ontario, but has trained people overseas as well. And this provides us with the extra competency-based training, knowledge, and skills to work to the real extent of our roles. And so many of us practice in more in medical traditional roles than my traditional physiotherapy role, working closely with either orthopedic surgeons or rheumatologists, and more on the medical management side of things.
I think these types of sort of interprofessional styles of care being delivered not just in Ontario, but in every province. Sometimes they call them different things, but the principle or the theory behind it remains the same, and that is you're freeing up time for the rheumatologist to be more focused on patients who really need their care and be able to work with patients sort of on a triage, like early assessment, but then also part of ongoing care. Is that correct?
Correct, exactly.
Yeah.
So the rheumatologist I work with, when we started working together back in 2009, his caseload was full. He had no space. And so by bringing me on board, picking up some of those stable follow-ups, but also seeing new patients, we were able to increase his caseload by about 50%. Now, both of us are quite full and struggling to keep up with the wait times, but it does allow for patients that need more of his time to have it, and perhaps patients that need a little bit more one-on-one time, they also end up on my schedule as well.
February is a busy time for you. It's the month where you have your pre-courses and then also your annual meeting that coincides with the Canadian Rheumatologists Association annual meeting. And it's certainly one of the events or milestones that's marked in everybody's calendar in the arthritis community in Canada. In terms of the AHPA, maybe to start off again for our audience, just tell us a little bit about who that organization is that you represent and who the members are and what sort of mission or vision that you have for the organization.
Sure. So the AHPA consists of healthcare professionals, researchers, and administrators from across Canada who are passionate about improving the lives of people living with arthritis. So we collaborate with other professional organizations as well as patient organizations to try to achieve our vision, which is optimal care and quality of life for every Canadian living with arthritis. And we do this through knowledge translation, engagement, and interprofessional collaboration.
Now, the pre-courses, we're in the midst of the pre-courses. There's 3 of them in February, I believe. And
Correct.
then that leads up to the annual meeting in the last week of February. Maybe to help us further understand the work the association does, maybe you can just highlight some of the work that's being focused on during the pre-courses, and then maybe some themes or important presentations that are going to occur during the annual meeting.
Sure. So our pre-course, it's the first time we're doing it virtually, and it offers us the chance to center around some themes. And this year we've chosen to take the theme of Twin Peaks. So we have 3 different sessions, and during that session we have 2 different speakers talking about different aspects of the same theme. And so our first session this year was on rheumatoid arthritis, and our first speaker talked about younger onset rheumatoid arthritis and the challenges faced in pregnancy and breastfeeding. And our second speaker talked about elderly onset rheumatoid arthritis, and possible differential diagnosis to consider in the older population as well. Our second session, which was held earlier today, was all about Indigenous care, and we did have a talk on looking at systems inequities, and then the second care was more on one rheumatologist's personal perspectives and experience providing care to one of the remote Cree nations on James Bay. Our third session is actually on virtual care. And so we have patient organization Cassie and Friends talking about how they've transitioned to providing virtual care. So each year during our pre-course, we always try to involve one of our patient partner groups. And the second talk is going to be by a physician who is very involved in the technology, virtual platforms, and kind of what's up and coming and how that might actually change the way we deliver virtual care in the future. So some very diverse topics, but really timely topics for our pre-course sessions. And then during the annual scientific meeting, we have a lot of things happening there as well. So there were 9 abstracts by AHPA members that were all accepted and are going to be poster presentations. We also have a podium presentation by one of our members on spondylitis. We have 3 workshops that are happening. One workshop about nutrition and arthritis, one on mental health in a pandemic, and transition issues from pediatrics to adult care. One of our members is partaking in a symposium on virtual care and looking at how we can map out virtual medicine in Canada for the future. For the first time, we actually have one of our members participating in the Great Debate, which is really exciting. So she's going to be on the stage for that. And then we're also having a networking lounge for CRA members and AHPM members to look at collaboration and how we can better work together. So a lot of really exciting things happening during the ASM.
It's fantastic that I think that you are able to do it alongside of the CRA. There's a tremendous energy and a tremendous synergy when you attend these in person, and I'm sure that'll be captured virtually as well.
Right. Yeah, and absolutely. And Sue has been a driving force behind this. She's the current chair of our pre-course committee, as well as sitting on the CRA AHPA ASM committee. So she has been working very hard. And then there's our board members as well, who have been involved in the education and moderating sessions.
When we talk about arthritis health professionals, what professions are represented under that umbrella?
Good question. So we have a wide variety of professions. We have nurses, physiotherapists, occupational therapists, social workers, dietitians, pharmacists, kinesiologists, chiropractors. Hope I haven't missed any. I think that's the big group of diverse healthcare providers. And then, as I mentioned, also researchers who may come from perhaps a health background or purely health research based, and then administrators from many clinics who work on the front lines, answering the phones, booking appointments, maybe helping with research studies, and administrative support.
It's the whole healthcare team. If you're fortunate enough to be living in Canada and have access to all of those professionals, those are members of your team. You mentioned a couple of areas, and certainly over the last 9 or 10 months during the pandemic, they've really been exposed and awareness has been raised around them. And that is around virtual care and health inequities, healthcare delivery in rural remote communities and Indigenous communities. Those are 2 of the areas that ACE is focusing on as a public policy priorities for 2020 on and beyond 2021. And it seems to me that the AHPA has a similar focus. So if we just turn first of all to virtual care, maybe you can share with us some of the work that is not only being presented, but that work that you've done already in that virtual care arena as it relates to these different professions. What's the experience been over the last 9 months? Where do you see it going? And I'll also ask maybe to call upon your personal experience, because If that bio that I gave at the start wasn't full enough, that resume, you also work with the Sick Kids and Children's Hospital in London. And there you deliver collaborative care for children with arthritis through telehealth. So I wouldn't mind asking you not just what the HPA is up to in this area, but maybe just draw on some of your personal experience as well.
Sure. So early on in the pandemic, certainly we recognized that many of our members were having to transition and figure out virtual care. As an organization, we don't create a whole lot of content, but we really try to partner with our members to figure out resources that are needed to find the most available resources. And so one of our members who works for the Arthritis Society in Ontario had developed a virtual physical assessment tool for arthritis. And so she gave a webinar to AHPA members, but we also opened it up to the ORA and CRA members as well, so that rheumatologists could attend and talk about, what are the different components of actually doing a good virtual physical assessment. She mainly was talking about the use of webcams and web platforms, but we also recognize that virtual care can be delivered by telephone as well. And so many of those same strategies can transfer over to telephone care, figuring out ways to do a physical assessment. The same member, Jocelyn Murdoch, is the one who's actually participating in the debate on virtual care. And she's also involved with the CRA in terms of a working group that they have looking at setting standards for virtual care. And, what do we need to know? Moving forward, also we're looking at our work as AHPA. How do we support this ongoing? What things virtually can we do? Because we're not connecting in person anymore at our annual meeting. So how do we bring some of that online? How do we do clinical and peer learning in a virtual world as well? So personally, I have had to transition my practice as well, and mainly to use of telephone in our adult rheumatology clinic. But a couple of years ago, we had started developing care for our kids living with arthritis, because we do not have a pediatric rheumatologist in Northwestern Ontario. Everybody has to travel either to Toronto or to Toronto or to London. So once a month, I do a virtual clinic with sick kids in London, so that our kids don't have to travel as far. Many of them still have to come in from our rural communities in Northwestern Ontario or from our First Nations reserves, at least to Thunder Bay. But then I do the physical assessment, and then we meet online with the pediatric rheumatologist to put their plan together and then coordinate care closer to home. And this allows families to travel when they need to. Certainly during the pandemic, again, we've had to shift a little bit more. So for families not being able to travel out, and just how we adapt to that. So part of that process of figuring out with families what makes the most sense, what meets their needs. Do we do some of it just directly from the rheumatologist to the families, and then pull me into the middle as needed to have them if they have to travel? So it's been a lot of learning as we sort this out. I've also found that, telephone care has been great. Some of our patients love it. They don't have to make that trip in. We can do a lot of what we need to do to touch base by phone. Many people have jumped on board with learning how to do their own physical assessment and are really quite capable of it, and then come to the next appointment, which we still find ourselves on the telephone again, with their physical assessment done and their report of what they know is happening. So it's been a really empowering for many people as well. I also find for many of my First Nations patients that the conversations are really different, that, without having to add those multiple flights and coming into the big city and the stress of being in a rheumatology clinic in a hospital setting, that when we talk on the phone, we're getting to completely different issues that we probably wouldn't have covered in an in-person visit. So there's a lot of value to virtual care, I think. And as we look at how we transition moving forward, have a place in our day-to-day, and when do we need to see people in person, and what can we do virtually as well?
Yeah, we're just in the midst of finalizing a summary of results. We've done a national survey on virtual care for our members and subscribers, people living with arthritis. I think I can say, from a preliminary standpoint, and we've seen this over the past few months in other surveys with other patient groups as well and therapeutic areas. in chronic disease, that overall, I think it's been a fairly positive experience. Similar to what you're describing, there are benefits for people living with serious chronic diseases like inflammatory arthritis, who have mobility issues, who have transportation issues, who just getting to that appointment can create a lot of stress.
Yeah.
And for people then to be able to bystep that and be able to communicate to you directly from the comfort of their own home with no distraction, there's absolutely some real value there. But also, we do know we don't want anyone left behind as we start to expand the use of virtual care. And that is, whether you're talking about email, whether you're talking about telephone, whether you're talking about video conferencing, people have different levels of digital or virtual care literacy, as well as the equipment that's essential. So you talked about, how AHPA, CRA are going to be working towards standards. That's obviously critical. We have to have sort of this baseline, these common platforms, if everyone is going to benefit. And that leads to another question, and that is, another fault line that's been exposed in healthcare delivery during the last 9 months has been the whole issue around health inequality and inequity. And that can relate to patients living outside of the city. You talk about you're in Thunder Bay. What is it like for people in London, Ontario? What's it like for people in Toronto? Obviously very different. And also the Indigenous community. I know in your second pre-course, you looked and focused on Indigenous care. I'm wondering if you can comment on maybe some of the themes that came out of that second course, and some of the work that AHPA is doing in this area.
So our session today, there was a lot of discussions about, looking from a systems perspective. So Dr. Barnaby was talking about her experiences in research, and, really looking at how do we make some systemic changes, right? So what do we need to do in terms of how we deliver care, where the funding is, and there's unfortunately, no simple answers to this, and it does vary from province to province, right? And then add in the layer of federal funding under NIHB and how that can be complicated, but different in every province as well, as to how it rolls out. So I think some of the themes that came out as well were that, that each, actually, Dr. Henry Averins also presented on his experience and really talking about that personal responsibility to, when you're delivering care, whoever you're delivering care to really know about what community this person comes from. What are the realities of what's available in their communities, what it takes to have that appointment. If we book an appointment at a certain time of year and people can't travel to us because the roads are bad or because ice is breaking up and there's no ice road or no boat, all these different factors that we need to understand just the realities of a community, and then the patient in the midst of that as well, right? The person living with arthritis. And certainly for Indigenous care, understanding, the results of colonization and our experience as settlers, what we need to understand and recognize as we move forward and try to deliver better care and work as partners to improve that. So I think there's a lot of pieces, actually, a lot of good pieces that have fallen out of there that we're, as an organization, actually hoping to spend a little bit more time in depth, maybe looking at and teasing apart some of these things, and how does that apply into our clinical learning, and how this may change the way we deliver care.
If we have people watching today who want to get more information on some of the things that you've spoken about, where can they find that?
Right. So we do, ahpa.ca is our home website. We're currently in the midst of actually updating and redesigning that website, so that it better suits the needs that we need today, versus when it was first designed 4 or 5 years ago. So We have a little bit of information in there, but not a whole lot actually on the public site. The site has been designed more for our members, but that it's a really good point and a good question about having a little bit more information about the team members, about the different healthcare provider roles, differences across the country. It's one of the things that we've talked about, actually trying to look at even bringing just the healthcare providers together to say, you know, in your neighborhood, here's who exists, right? And for patients as well, how do we actually create that to say, yeah, this is what exists in your neighborhood. This is who you should know that you can have access to and that you can request access to. So many people access, for instance, their rheumatology care from a distance, right? So if you live outside of a large center, you may actually have to go to a large center, but, you know, does that rheumatologist know what exists in your community or your area? So how do we better link those things together? We'd actually started to engage in some of that just before the pandemic and got sidelined a little bit. So it's a good reminder to come back to these things about, you know, how do we actually create a bit more of those links, and on our website having a bit of information and directing people and people living with arthritis to some of those links.
We don't have centers of excellence in every province like cancer does, and arthritis should.
Yes.
And while we're trying to achieve that, and it's going to take some more time, for us to work collaboratively and maybe put together those resources, a one-stop sort of source for those resources, it might be something that we should be talking about, and something that probably our patients would really appreciate.
I think that's a great idea.
Well, listen, I know it's a very busy week, and we thank you very much for taking some time off to spend with us. And we're hoping that people will go to your website and also look out for news coming out of the annual meeting. As we said, it coincides with the AHPA and the CRA, and it's in the final week of February. And we look forward to talking to you again. We really appreciate your time, and obviously you're a big part of our lives, our patients' lives. And we thank you for all the work that you do.
Thank you for today. I appreciate it. And I appreciate the ongoing collaboration between our organizations. I think it only helps to improve the lives of people living with arthritis, and we need to hear what we need to do better. Yeah.
Great. Okay, thanks again. And thank you to our audience for joining us. Please come here again next week for another episode of Arthritis at Home.